tell us a little bit about your career path, particularly early on. What were the options available to you, and how did you end up doing what you're doing?
Well, interestingly, I didn't start off to do public health. I didn't know what public health was, and I wanted to be a psychologist. So I graduated high school in '74, so it's not quite 5 years after Woodstock, so drugs and behavior is pretty rampant. I really wanted to study drugs and behavior from sort of a nerdy, real science side. And I started off at the University of Alabama. Quickly realized that they had one experimental psychology course, one psych course that had a lab, and you couldn't really do drugs and behavior at Alabama then. It took me a while to figure that out, but I looked around. I found another spot where you could actually do that, and that was UAB, where every psychology class had a lab, whether you liked it or not. And it was taught by people who really were involved in that. A lot of the people were real science folks who were doing psychology stuff as well as psychology folks, and you're here at the medical center, and that was pretty exciting. Also, I could work in neurosciences. At that time, it was fairly new. This guy, Bill Bridgers, had been brought to Birmingham to start a neuroscience program. It was a very fun place to work. Everything we did, for the most part, every day had never been done. And I had an undergraduate job doing that. That was just fascinating for me. I got to the end of my time and was going to apply to graduate school, so I wrote to the best, what I thought was the best 5 programs around the country, and wrote directly to the chairman of the departments and said, how would I do what you do? And I thought that's where I wanted to go. And they all wrote me back, and they all said, first go to medical school, which was not really on my horizon. I'd been taking classes along, but it was to do psychopharmacology, so I'd really pretty much paralleled the pre-med curriculum, but had absolutely no inclination of going to medical school. So that just sort of threw a wrench into where I was going. So after graduating from here in '79, as an undergraduate, I took about 6 months and I went up to Hayden, Kentucky, which is not near anything. It was the only incorporated town in Leslie County in Appalachia. Don Palmer, who was the doc that everybody, if you were a doctor at UAB or around here, that's who you took your kid to. He was the pediatrician of choice. And he was going up there to do a sort of a sabbatical. He was taking over for one of his friends who ran the place up there. And I just followed him along up there. I was sort of a volunteer. They let me scrub in on surgeries and work in the lab, draw blood, hang out in the clinic. And I wrote PR for him. I wrote for the weekly newspapers and did nursing recruitment, go around to colleges wearing a coat and tie and try to get nurses to come work at the hospital there. They had a school of family nursing, where you could become a nurse practitioner, and this is in '79, '80, long before it's everywhere. And they had a nurse midwifery course. So they had the longest continuous operation midwife program in the country. And most of these folks were incredibly trained folks who'd been working overseas and stuff and come back here and would get actually trained as midwives and stuff. And I did their PR and stuff like that. And I got to live in Appalachia, which was interesting in itself. So I come back, I decide I would like maybe going into medicine. So I come back with the idea of actually applying to medical school. While I was in Kentucky, I helped with the school and I learned how to write grants a little. And I also learned about this thing called public health, which these guys dabbled in because they were looking at statistics of populations and stuff in the area. And I'd never done that before. It looked pretty fascinating. And since I'd already graduated and I was going to be a post-baccalaureate non-degree seeking candidate or student here, I thought I would take some public health courses to see what that was. So the funny thing was that the room this room's named for, Dr. Lehman, I show up on my first day of class in 1980, and the School of Public Health then was on the medical school calendar, which started 2 weeks before. I didn't know that. So I show up and they give me the test. It's absolutely the first day. The first way I met Dr. Lehman, he said, "Here, fill this out." It's okay. So, but Dr. Lehman was an incredible teacher. The school was pretty young then, and you were in, your classmates could be just about anybody. It was a master's program, so most people had a degree, but I'm not sure everybody did. But a lot of the people had a lot of degrees. So a lot of the people from UAB who were faculty were actually going through the public health program to get that sort of perspective, because it was brand new. It was, what, 2 years old then or so?
Mm-hmm. Yep. Established in 78.
And this was 82 when I was here. Dr. Bridgers wasn't even the dean yet. Who knew? So anyway, and it was very small, very collegial. You're right with these people. So you got physicians, nurses, administrators, accounting, economist guys, all, it's a multifaceted thing you do in public health. And there was somebody in every facet right there in class with you. And that was neat. Especially being basically still almost an undergraduate. People in your class were, it was a fun class. We didn't do teleconferences, and we actually used pencils and paper and punch cards and stuff for computers. And but you actually came to class and you discussed stuff, and that was really, really fun. I liked public health. It was still like public health. That was stimulating. I'd never seen anything quite like it. It was there was nothing you couldn't touch on the topic. Because what we're doing isn't working. Healthcare is not doing really well, so you got to look somewhere else. And you could look anywhere. And that was fascinating. Oddly enough, I got accepted to medical school. Right before that, I got accepted to winemaking school at California Davis, and obviously made the wrong choice. Could have retired years ago. And I went to South Alabama for medical school. It was okay. They didn't really care what I thought. They wanted me to memorize stuff. It was really hard coming from public health going into medicine, because they really didn't care what I thought. It was just, medical school has a lot to teach you, and got a short period of time, and what you think about it is not necessarily at the top of the agenda, as opposed to the School of Public Health, where it was the top of the agenda. I go from there to Medical College of Georgia to do a year of pediatrics internship, because children don't create their own problems in medicine, so I couldn't really blame them. So I didn't feel great animosities toward children. Children are fun. That's sort of how I made that choice. But I really liked psych, which was the whole thing I wanted to do all along. That program, I was on call this was back before the residency work requirements, so we were on call basically every other night, up all night.
And as my surgery colleagues would say, what are you complaining about? You miss half the cases.
Right, well that was the thing. The surgery folks had it better there than the pediatrician folks did. But yeah, we would miss half the cases because we were only up all night every other night per year. Had one weekend off every month. It was my National Guard drill weekend. And so I quit the program after a year because I was just exhausted, along with half the other internship group. And thought I was going to apply to psych residencies. So I could go do psychopharmacology research, which is what I wanted to do all along. And so I just got married. We moved back here. I'm working up on Sand Mountain at a clinic and finishing up my master's of public health here. And I liked public health again. Boy, I was back where you could actually think, and different group of people. It's been 6 years or so since I was here. Still an incredibly vibrant school. Classroom discussion is incredibly lively. Still an excellent group of experts. when I came back this time, there was actually a guy who was a cardiologist from like Puerto Rico or somewhere, who was head of the American, like the Americas, not U.S., Association of Cardiologists or something, and he actually would fly in from like Buenos Aires. He did all his homework on the plane. We were doing statistics and something else, and he did all his homework on the plane. I don't think he ever lived in the same place twice. And would fly from here to somewhere and go to meetings, and he was always on a plane going somewhere, and would be back here for like Mondays and Thursdays or Tuesdays and Fridays, and that was about the only constant thing in his day. But I mean, we had some really fascinating folks, and those conversations were really, really good. You're doing economics. You got people that are actually doing that every day in the class, and undergraduate type, or not people who've only got an undergraduate. That was fun. Anyway, I finished that up in '88, and then went and did med peds up in Ohio, and came back to Coleman. I was just talking right before we came in here about what happened as I got through with residency. Because, public health was absolutely the most exciting thing I had done, and I was trying to find a way to get back into that. So at the end of residency, I actually looked at going to work for the Epidemiology Investigation Service that folks out of Atlanta.
CDC.
Right, and that's a really fascinating program, and my wife said, you're going to be gone for 2 years. So you just get a go bag and you sit at home if you're at home, and you go somewhere, and if something hot's happening around the world, like this spill or something, you're there. And I thought that would be just fascinating. My wife didn't think so, so I didn't do that. I looked at going into the Army, because I was in the National Guard, and being a flight surgeon with the Army. And we were looking to go somewhere really fascinating, somewhere like Vicenza, Italy, or Europe, or something like that. And they're bringing everybody back then, and there is no fun place to go. They're not going to send me anywhere. And so she didn't want to do that. So we looked at being a public health physician, but I'm not sure what the program was.
Public Health Service Corps.
I guess. And two of the exciting places that actually had openings were Pago Pago and Guam. There would be two physicians on Guam. One did surgery, one didn't. I would have been the non-surgery guy. And Pago Pago, there's only one doc, I think, and it was open. I could have done it. And they would have paid me real well, because they would have taken my National Guard rank and promoted me up a bit. So I would have gone in like as a colonel or whatever in 06. It pays pretty well if you're going to be a starting guy. And that looked really exciting, but you can't take your dog. And so they wouldn't let us take Tom with us. We had a golden retriever that was our first child, and she would not part with that dog. So we didn't go. So I came to Coleman. And I did, actually I was supposed to go to Chattanooga. The guy I was supposed to interview with, his mother died. And they said, you got to go somewhere else and interview. So I could have chosen between Decatur and Coleman. I flipped a coin, we went to Coleman, and I've been there ever since. But it was not really intended. But so none of that was intended, by the way. I didn't really intend to get where I am, but it's how I got there.
As we were talking earlier, that's one of the messages that I hope that you hear in this, that I know it, for many of you younger folks in the crowd, you're thinking that you've got to make that next decision that's so critically important, because that's where you're going to be the rest of your life. That's not how it happens. That's only the next thing in your life. And
I've still not gotten to my neuropsychopharmacology program.
There's time. There's time.
There is time.
There's time. So now you've been in private practice in Coleman. What's a typical day like for you? Is there such a thing as a typical day in the life of a private practitioner?
It's long. That's the only thing that's typical. My particular situation is I have a pediatrics trained partner, so he doesn't do adult medicine. I have a nurse practitioner most of the time. She just delivered, so she's out for 3 months. And she sees adults and kids. She's new to us, so we've always had somebody that has done that, but currently we're without a nurse practitioner, so we're sort of taking up the slack for that. We see folks all the way from birth to end of life. My oldest patient was 101, and Christmas she got ill and sort of passed out at a Christmas party. She was completely walking around on her own. She didn't drive anymore, but she didn't use a walker or anything. She was sharp, did her own taxes up until about a year ago, and was not on a whole lot of medicine. So that was my oldest patient. So I span pretty much from attending deliveries to end of life on that. And we don't have particular intensivists and that sort of thing, so I'll see people in the ICU, we'll go to deliveries, see people on a regular floor, plus I run an office 5 days a week. I guess most people, if you're a pediatrician, you're probably seeing ears and coughs and well checks and stuff like that. We see a lot of well checks and that sort of thing, and that's fun. A lot of my well checks are more complicated folks, so yes, they're well, but they also are in a wheelchair and they have a feeding tube and all this sort of stuff, because nobody in Coleman really wants to do that, so I've sort of ended up doing a lot of that. We're on call, like real doctors, like if anybody's old enough to remember Marcus Welby or any of these old country doctor folks. It's a lot like that. We actually take call and that sort of thing. I was talking with my wife about this before I came here today, and she said, but you hadn't mentioned anything about what you do. I said, well, really? So, up until recently, I still went to nursing homes. On occasion, I'll still do home visits just because it's easier. Usually just because I'm driving near where their house is, and it's silly for us to all drive 15 minutes back to my office if I'm already there. So I actually do some of that. It's a small town. A lot of people, in a small town, you don't really know a beeper because you don't need a beeper because everybody knows where you are, And, oh, he's over here. You get a lot of that. Healthcare itself, just taking care of patients, takes a lot of my day. Every now and then there's a meeting or two, administrative stuff, and sometimes there's some community involvement stuff you throw in because you live in a community. That's part of what you do. But it's really fun. I like it. It's a long day, and it's sort of grueling. I don't think most people would want to go into it. If you're wanting to make money, it's not where you want to go. It's not procedure oriented.
It's that psych pharmacology. Is that where the money is?
And the big pharma is a really good place to work. They have more expense accounts than we do.
So you have your MPH. You're in clinical practice. How do you use your MPH in your practice? What special lens, what special perspective does that have for you in delivering clinical care?
Ever since medical school, when we were doing family trees or family history, the guy that taught me in medical school was really into this Bowen family theory stuff, and we had to draw these monstrous family trees. I had one guy in medical school, he had been married 7 times, had a child with each wife, and wow. Et cetera. And I'm on the surgery service. All they want to know is, why are we doing surgery? And, they really didn't care about his second wife's medical illness and that sort of stuff. But I was taught that sort of stuff, and it was amazing to me. If you actually draw a family tree, if you see a guy's married 7 times, that in a picture, that's a much different home life than if you're seeing a guy that's just married once. All the kids are with the same union, nobody's divorced. I mean, you can imply a lot from that. What you're going to see, are there barriers to care? Is there a lot of anxiety in the home? You can find a lot of that stuff. So I actually look at that, and by the time I've finished my first visit with you, I pretty much know where you are, and I'm probably using that without knowing it to look at barriers to care. How can you get to the office? Do you still drive? Does your insurance buy your prescriptions? So am I going to write what you really need, or am I going to like compromise and give you something that you can afford? Or are you going to go to Publix and get the free stuff? Because they actually give you free stuff at Publix. Why would you not? Some people, that's all they can afford. They can't afford that because they can't get to Publix. So you look at some of that. There's not a lot of options necessarily for that. I mean, as a single person, I don't really influence that a lot, but I can help my patients with that problem.
But just understanding that there are those larger dynamics, those larger forces at play, social determinants of health, you know those well. Taking those into consideration as a practitioner must be both daunting, yet it has to inform what it is you do.
It does. It's, I mean, they're really, I mean, all those things that, I guess World Health Organization or whoever's doing all that, I mean, it's out there. All of those things are real. There are probably a couple other things you can throw in that mix that affect how your health is. What do you do for a living? Do you actually have money? Are you worried about food? We actually have, one of my patients, she's a type 1 diabetic, wears a pump. My wife's a pump trainer, so we know her a lot. She talks to us a lot. We're trying to keep her out of the hospital because she has this histrionic personality disorder and incredibly, more than most people, enjoys being in the hospital. It's her get out of the family thing and stuff like that, has been for years. Years ago, she used to actually spend more time in the hospital than not. She's actually doing pretty well now. We've, for 15 or so years, we've actually made some headway on that. But she was coming in a lot all of a sudden, which I didn't really understand. And one of the nurses picked up that they didn't have food at home. Her husband doesn't work, she doesn't work. They really weren't on disability. Her son works sometimes at Denny's, sometimes brings food home. He lives there now with his girlfriend, fiance, and she was making the family feel really good about stuff and making sure they had plenty to eat, but she wasn't eating at all. And that's why she was coming in so frequently. So, it's not really what I thought I should be looking at, but all those social determinants, other determinants of healthcare, affect my patients every day. They affect populations differently, but you take a whole bunch of my patients and it becomes a population. So that's how it's affecting you. And so I look at that. I mean, you have to. It's what can you do about it? I don't know. Rural Alabama, or not urban Alabama, is sort of underserved for many of those determinants of health. Yeah. And certainly a career for somebody out there, but it's not a completely unsolvable problem. I mean, it should be really exciting if you're in the School of Public Health, because something can be done about it, and probably very well. So,
let me just check in with y'all. Any questions up till now? Any comments for Dr. Addison? So the question, if you couldn't hear it, Mona was asking about Dr. Addison's service on the Coleman County Public Health Board.
So in Alabama, the Board of Health is made up of physicians in the county. It's sort of I'm not sure that I completely understand it, but legally from long ago, that's the way it's been, and it's sort of a subset of the medical society, actually. Yep. So if you're there long enough, you get on that, and so everybody else being able to get off, I got on several years ago. We're not really active as a for the most part. The chairman or whoever, the president or whatever it is of the Board of Health gets to appoint the county veterinarian. That's a pretty exciting role, and there's not a whole lot else we do. Most of public health, for the most part, is run by the State Public Health Association or State Department of Public Health, and through the counties. But we're there, and legally we're there as sort of the last arbiter. And so if there was an outbreak or a problem or something we saw, you can, it's a real entity. We've tackled a few things, but they're more like logistics and stuff for the Department of Public Health. It's not real exciting work. It's more, we haven't had anything real exciting to do, which is good.
It's a good thing.
If you do prevention, nothing happens, right? So prevention, maybe from the public health prevention side, maybe that's working good.
So Mona asked, and we can certainly go to this place when we talk about some of the issues and some of the special problems that you experience in your practice. One of the conversations that we've had is your concern about fatherlessness and the impact that has on families and family well-being. You want to speak to that, please?
2 or 3 years ago, Dr. Michael asked me to come down and sort of do sort of this same sort of thing within a class he was doing, and wanted me to pick a problem that I saw every day, and we were going to give the undergraduate students a chance to wrestle with it, and I was going to come back in a couple of weeks and we were going to see what they had figured out how to solve my problem. So I'm looking for a really cool problem, and I said, well, most increasing proportion of our moms who deliver are not married, which has been a marked change in my number of years there, 20-something years in Coleman, going from almost everybody being married to almost nobody being married. And the same trend you see nationwide, where there may not even be a dad named on the birth certificate. But initially I was looking at that from the idea of teen pregnancy, which was, back when I was in school here, was the big thing. Well, that's not necessarily a big problem. It's teen pregnancies going down, births to unmarried women is going up.
Unmarried older women, so.
Yeah, and primarily older, I don't know, late 20s and up. So that was interesting. So I was looking for the problem of teen pregnancy, and it's not there. So I was trying to find another problem, and I'm looking at this, and I'm saying, well, if it doesn't really seem the problem so much as the women who are having children who are not married, but where are the dads? Nobody's counting the dads. There are no public health data counts births to women who aren't married, but they don't count the dads. They count teen pregnancies, they count a lot of things, but the dads aren't counted. I said, wow, this is cool. They'll really like this. I thought I was just discovering something entirely brand new. And I started looking into it, and I mean, it's been going on since the 60s. So the early 60s, people have been doing tons of research on the importance or whatever of fathers and families, involvement of fathers and families. And I was just fascinated with the whole literature, because most of the problems that I see in Coleman and that affect my kids in my practice and even the adults in my practice are, 80% of inpatient psychiatric admissions for adolescents are people who come from fatherless homes. Almost all teen pregnancies occur in father to children from fatherless homes. Almost all incarcerations, arrests for teenagers and other come from families that don't have a dad in the home. If you're, it's getting to be pretty prevalent to actually be in that group. And if you're in a two-person, two-family, mom and dad and kids in the home, no matter how much money your dad makes or whatever, you're probably not going to necessarily dip into the poverty category in your home time at home. If you're in a single parent home, I think 30% of people will have experienced some period of true poverty in the time from birth to you're 18 or so. So if you look at, all those socioeconomic things that affect health, it's all related to that. And so that was just amazing to me. Then I was supposed to do a talk in Coleman to, I'm not even sure who it was for. I guess it was for our school nurses or somebody. And that's when I said, I'll just do it on fatherlessness, because I knew there wouldn't be anything in the literature on that. It would be a really, really easy thing, and I was sadly mistaken. And had 6 months to try to become expert on that, and that's really not enough time. Fortunately, there was a guy who's a public health, ran the Richmond County Public Health Department up in Virginia. And I don't know how in the world I got in touch with him. He walked me through everything I needed to know. They've got a really cool program there where they take every department in just about every department in the county. The county and the city are the same in Richmond. And they took 1% of their budget, like the DA, police department, jail, public health department, the WIC sort of stuff, food for kids, public housing, treatment for addictions. All those people took 1% of their budget and pooled it into this thing, and it's their fatherless initiative or fatherhood initiative or whatever they call it, with the idea that they would take local churches. So you got faith-based organizations multiplying this money. So there's a huge amount of money coming in, and most of it's not going to salaries. Most of it's going to actually operations, and they actually have people to help guys when they're getting out of jail so that they don't go back to jail, reincorporate them into the home, and keep them in touch with their kids so their kids are not necessarily fatherless. And people in these communities will get these guys jobs so that they're actually making money, so the mother of the child actually wants to be with him now. It was just amazing that all the things that, and if your dad has a job and you move out of public housing, now we're not paying necessarily for Medicaid, we're not paying for WIC, we're not paying for public housing. So budgets are, that 1% investment of your budget in your part may actually reduce your overall cost. So that sort of thing has just been fascinating. So sort of morphing from fatherhood, my new interest is somehow trying to solve these social ills, whatever they are, using government and faith-based organization partnerships, which, if you want interesting reading, is next month's American Journal of Public Health is devoted to that, sort of. It's more than you'll see most places.
Right.
And so that's, if I was going to do research on something, that would be where I would really want to go now. It's got to be some way to do that. It seems to be more successful than most of the other things we've been throwing at these for a while.
I'm reminded the first study that I was ever involved in after I got my MPH. I was in Karachi, Pakistan, and we were doing a study on child mortality in the squatter settlements of Karachi, where it seemed that everyone had exposure to multiple potential bad outcomes. The single most important predictor of a family having a child death or not was the stability, not the amount, but the stability of the father's income. And that was in an era when there was so much being written for the right reasons about the power of mother's education for child health and survival, and finding this one piece about the importance of fathers in the household, I think was a fascinating finding. I think part of it has to do simply with the social dynamics where we've evolved in this day and age, that it is acceptable and fine from a societal perspective to have children without having the typical the typical core family, and that there are challenges with this. You mentioned the Coleman County Board of Health. I'm wondering, Dr. Addison, how your knowledge of public health connects you with other entities in your community, whether they're governmental or nonprofit organizations that have to do with communities and populations, so that, again, it takes you out of your individual level clinical practice and allows you to wear your public health hat. Are there other entities with whom you're involved there in Coleman?
Probably the thing for me, most of it is working on the staff of the hospital. I think they call me the chairman of the Department of Medicine. It's not quite as prestigious as it is here at UAB, but it is, they don't necessarily work for me. But we're part of the group. The medical staff officers sit in a room and determine how the hospital is going to respond to what we do in our population, how we're going to serve that group. And over the years, being able to look at population trends, and things like that, and even know that you might want to do that. I mean, I'm one of the few people that have at least been exposed to that. Not that I'm expert in it, but I bet most of the people making those decisions have not even been exposed to that. And it's I've been able to sort of at least back up. You can ask a question or two and help the discussion get back to where it may need to be. You may provide the care differently than we were doing. If people from outlying communities can't really get there, maybe we can get to them. So, and maybe we can partner with people to do that. So instead of people having to come in from the periphery of the county into town, if they don't really have transportation and that sort of stuff, maybe you can take the flu shots to them. And since you don't really have, we're not big enough to have multiple sites for our county health department, you can go to either high schools, you can go to elementary schools. I mean, a lot of the kids will get their immunizations there. But for families, you can go into the senior citizen centers, which are fairly well attended, and things like that for prevention. For one of the things that when I was in public health here, the thing you wanted to know to drive if you wanted to know one piece of data about a country or an area, was the infant mortality rate or the highest level of education mom had at her firstborn. That was the big predictor. It's a little more complex than that now. But I mean, probably the other thing is just from a public health standpoint, when people are sitting in a room talking about stuff and they throw out incidence and prevalence and stuff like that as if they're the same thing, you realize that you got a long way to go, you know, when one time they say this and one time they say that and they don't understand that, or they don't understand, like the news this morning that said the states with the 5 biggest percentages of people on Medicare. One was Maine. I think Maine tops the list. But that's not necessarily more people. And that that would occur to you. I mean, you get a lot in public health. You really are, probably the biggest thing public health has done for me is made me be able to read an article and critically think through, one, did they even set it up right? Did they analyze the data correctly? And even though it's in a peer-reviewed journal, that doesn't mean that happened. Okay?
That's exactly right.
And did they reach the conclusion you could have? Did they overreach? Is this more a political agenda, or is this really substantiated by the data? Hopefully you get that here. Hopefully you still get that here. That's critical thinking is in whatever area, but being able to read what's before you and you know, somebody uses this article to say that this is the way we should go. That's not really what those people said. And that's been really instrumental in a lot of things we've done at the hospital. Sort of mundane decisions, but it could have been really worse if there hadn't been people to actually ask the right question. You know?
Well, I knew that you were putting your epidemiology hat on in a conversation before we came up here and thinking about the difference between incidence and prevalence when you said that one of your goals in life was to increase the prevalence of chronic diseases.
That's what you do as a primary care doc, right? So you wake up every morning and your goal is to increase the prevalence of chronic disease.
Right, because you want to save people, right?
They should not die today.
Right.
So they're still going to be on the roll tomorrow.
Right.
And if you do that for enough years, I mean, you think the government would stop funding us.
Somebody will get it one day. So we're at time, and I want to allow you to make any other closing comments that you'd like, Dr. Addison, but again, want to thank you for being here.
I don't know that I told you that I really liked public health. That's, when I was here my first go around, we would have public health picnics, and they were usually pig roast. If you can only imagine epidemiologists roasting a pig, everybody's got a thermometer. But they would be out somewhere, and you dig a hole in the ground, you have this big pig roast, and all the school would show up with family and kids and adults and grandma, and everybody would come. It was really, really fun. And when I came back in after medical school, it was the same thing. We did public health happy hour instead. Dr. Lehman played trumpet. Most of the faculty played something. Many of the students would play stuff. We'd go to a local establishment and take over something on Friday evening. And it was really, really fun. But you worked hard when you were here. But it was really, really collegial. But that collegiality really extends beyond class. I would think if you pick up the phone and call somebody in public health in another state or so, it's going to be a fairly warm welcome. It's a lot more fun than the medical side that I do.
Great.
And I think even if it's not your major way you're going to earn your living, if you do something with it or bring that into what you do, it's going to probably make your day more fun. Every chance I get to interact with public health is usually a more fun day for me.
Great.
So it's hopefully you'll, even if that's not your ultimate life goal, hopefully you'll still keep some involvement with that.